Hi, What the HealthTech listeners. I'm your host, Paul Johnson. Welcome to today's podcast. This is the podcast where we tackle some of the trending topics, challenges and best practice within health and social care. And I'm joined today by our very own Mark Fewster, our Chief Product Officer.
Hello.
Welcome, Mark.
Thank you very much.
So I think today we're going to have just a general conversation, a little bit of a chat, but something that is quite new for us as an organisation.
Yeah.
In fact, I'd like to say it's a world first, but I'm always nervous to say that.
No, I think it is a world first.
Yeah. Is IHI Triggers, which I let you give a better description of what that actually means. But I think in terms of what it means for healthcare providers, and especially where people are integrating to those patient records. IHI Triggers, so what does that mean?
I'll start with the acronym. So IHI is the Institute of Healthcare Improvement. Patient record. Within a patient record, you might have determinants of something that might have caused harm to a patient. And so the IHI element, the Institute of Healthcare Improvement, one of their processes, one of the things that they ask clinicians to do is review a certain amount of records. And within those records, they check for these indicators of harm. So a few examples might be somebody's had a long wait time in A&E, for example, and then you check that against the patient record and then you subsequently check, did that end up resulting in an incident in some way, shape or form? We're basically digitising that process where you no longer need somebody to go off and to check these individual records. We plug into the EPR record. So if you think of electronic patient record systems out there like maybe Cerner and Epic, within there, and I've got more acronyms to go through. Within there, we've got particular triggers that we can pick up on. So I'll have to read these off a piece of paper, I'm afraid, because otherwise I don't remember them. But the types of things we can plug into, so ADT, which is admission, discharge and transfer messages, ORM, which are basically lab test results, OIU, which are basically things that contain specific observations about a patient, and then RDEs, which are medication orders. So to turn those into things that actually make sense. So examples within general care, for example, might be a patient fall, a pressure ulcer, cardiac arrest, deep vein thrombosis, maybe readmission into the ICU. So somebody's been in the intensive care unit and then has gone back in within a certain period of time. Specific lab test results. So again, within this patient record, somebody's gone and maybe MRSA has been detected within that patient record. Unplanned readmissions into theatre, specific medication orders. So again, terrible pronunciation here, but naloxone, flumazenil. So specific types of medications that are being prescribed to people. And then things within specific areas within the acute in this particular case. So labour rooms, blood loss, lacerations, instrumental deliveries, and then emergency department. Things like waiting times within ED. So interestingly, the one we're working with at the moment, which is Cerner and EHRs within the Middle East, are long wait times in the ED department, and their classification of a long wait time in the ED department is actually 6 hours. So these things, these determinants, what's happening is rather than somebody having to go off and review this data, or traditionally somebody then raising an event because this ends up being an incident in some way, shape or form, we're plugging directly into the electronic patient record. We're then generating a workflow from that within Radar, which is typically a triage step, which is almost like the clinician would be doing. Has this resulted in harm in some way, shape or form? We can go a step beyond just the direct trigger though, and we can put some logic in there at the point at which the thing's generated. So those examples I gave, as you imagine, you just switch that on tomorrow and suddenly you're getting lots of alerts.
So all these things they're hard-coded within the patient record?
Yes, absolutely.
And there's a reliance...
these are the message types, the triggers.
So all those messages are in there.
Yeah.
And there's currently a reliance on somebody to go in and review that information.
Which may or may not be happening.
May or may not be happening. And then once you've reviewed that, where applicable, that you would record something in an incident reporting system like Radar Healthcare to then generate and do the doing.
Yeah, so if you think of some, a couple of examples I gave at the top there, the patient fall and the pressure ulcer, traditionally, with a system like ours, you duplicate an effort because you're recording that in your EPR and then you're going off within your other system, hopefully Radar, to be able to raise an event, which would be the fall or the pressure ulcer. So we're just automatically picking that up, bringing the data that we need through from that patient record, triggering them in that workflow process. So one is we're actually making sure that people are reporting these things in the first place because it's coming from the EPR. And one of the things we've seen with some of the customers we've switched it on for already is there has been an increase in reporting. Just because now you're taking away that discretionary element when you say, well, actually, if this thing happens in the EPR, in the patient record, there will be an event, there will be a workflow process generated.
And do you have a sense of, I mean, it sounds like there's so many demonstrable, tangible benefits from it. You just mentioned there about potential underreporting because it's time, effort and energy that healthcare workers just generally don't have. So you've got underreporting.
I mean, just on that, if you think of even within our system, the amount of time it takes for somebody to fill in a form and when they do it. So let's say, for example, there's been a fall or you're recording a pressure ulcer. You as the person delivering care, typically a nurse, let's say for our example, you may not have time to do that immediately. So then you've now got the risk of whether the thing actually gets recorded or not. And then when you actually go and record it, it takes some time. And what we've seen with Radar in terms of when people are doing this is sometimes they're doing it after the shift. So they care enough that they want to put this thing into the system. Yeah. But because they're so time pressured and because they've got, obviously, they're about delivering care, they're putting something, raising an event, raising an incident, comes later, they still want to do it, but they end up having to do it off their own shift, so in their own personal time. So all of that, frustration around, I've got to go fill something in, and the time element of it, we just completely remove that.
And I suppose the time to respond must improve.
Oh, absolutely, because exactly.
Something's occurred, it's now triggered, it's been surfaced, workflows generated, actions disseminated and tracking this thing.
Yeah, and even if these things are just super simple triage, step and close down, so if you think of the maternity examples there of issues within the labour room, those can just quite quickly build up a picture of what's going on within the organisation, whereas typically they might not have been recorded or reported in the first place. Or you would have had to go somewhere else to pick out your analytics, to do some in-depth analysis within your EPR to figure out what's going on. So all of that clinician time as well, now that's completely abstracted out because it's all flowing through into our analytics platform. And then the artificial intelligence that sits over our analytics platform looks for the patterns, looks for the indicators of maybe there's something wider going on within an organisation or across different organisations.
And then, I mean, you mentioned Cerner and Epic, which are two, big names within the patient record. This is applicable to
anyone. Yeah. I mean, so the example we're talking about here is IHI Triggers, and similarly, I mean, we're kind of jumping around a little bit in terms of some of the questions we're asking, but part of what we're doing with the API technology we're building out is to be interoperable with anything that, in a sense, is going to be the source of what might be a potential risk. So if you think of the things we're talking about here, very straightforward examples of this, may have caused harm to a particular individual or did cause harm to a particular individual, you can expand that out into some of the work we're doing with some of the care providers in the UK and integrating with their care software providers. People like Nourish and PCS and Caring, for example, we're integrating with those. And then moving a step beyond that, and again, in terms of how risk is evolving within organisations, it's becoming less centralised and less around individuals manually tracking information, for want of a better way of describing it, to something that's becoming a wider ecosystem of technologies and providers. So think of a geography. You might have, obviously, your hospital. Within there, you've got an EPR system. You've then got care homes. Within there, you've got all the care planning providers. You might have care at home, where it's wearables, IoT devices. These might all be provided by lots of different suppliers. And actually what we're doing is we're aggregating all of that information from all of those different areas and giving that centralised viewpoint on risk, for want of a better way of describing it. So how are these things being managed? Are they being managed? Are they being used properly? Where they are being used properly, are you making sure that you're generating the right, for us, Radar word, but workflows to the process and things that you need to undertake when these things are telling you that harm's happened or you need to intervene in some way, shape or form.
Is that the vision then for you and Radar Healthcare? You're ultimately responsible for Radar Healthcare in terms of the product. Is it that you see it that it becomes, you just plug Radar into whatever that data source is or whatever that system is, Absolutely. And let it to start to automate what the necessary response is?
Yeah.
You mentioned there about the analytics and the artificial intelligence that's then push through that to then affect a response and a change. Is that so? Regardless what the system is, simply plug in Radar Healthcare, let it start to connect to that data and.
I know when we talk about let's say we're on a sales call, for example, and we've got an organization who might be acquiring lots of other organizations. We always talk about radar being something that can just go in and then underpin. So actually, you've got a way of running your particular organization, processes, policies, all that kind of good stuff. You buy another organization that comes in and radar's just there, and it makes sure that this new element to your organization runs in the way that you want it to run. Expand that out into all the other things that you might be doing. So you bring it on a care platform. You want to make sure that the workflow is being generated from that, and how you manage falls, wounds, whatever that looks like, again, is managed in however you determine that process should be. Same thing for the IoT devices, fridge monitors, anything in that ecosystem of risk. We plug straight into radar, and then radar just basically underpins and gives you that assurance that, one, those systems are running as you expect them to be running, but probably more importantly, when they are shouting and saying that you need to be doing something, you have a digital process and a workflow that basically is going to ensure or mandate that process is happening and that thing's taking place. And then on top of that, using things like our audits module and schedule tasks to make sure that you're maintaining these things. So if you think of wearables, fridge sensors, all that type of good stuff, you're not only wanting to get information from that in terms of things like readings and is it working, or when it breaks, what happens, but you need to make sure, are they in, are they working, do they have batteries in? So the whole maintenance element of this kind of new infrastructure, again, we underpin that as well.
I know you touched on there about artificial intelligence, machine learning.
Mm-hmm.
These are getting bandied around all the time. And what, from your perspective, what does it mean? And how you view it as to how you apply it? Because one of the things I always hear as well is RPA, robotic process automation, which sometimes people do assume there's robots and androids walking around doing things, but maybe if you just from a chief products officer's perspective, rather than me trying to articulate what I think it is what does that mean? And then, from a radar healthcare perspective, when we're talking about making organizations efficient by some things you just discussed, maybe from your perspective, what RPA and...
So I'll start with the AI one.
Okay.
Not because it's simpler, but probably because kind of easier to give an example of it. And I guess, everybody kind of, AI is a little bit of a scary word for people. For us, if we roll back to those examples around the IHI triggers, or information that's going into a system, traditionally, and let's just pick kind of, quality management for argument's sake. We're a couple of quality managers, or we're working at a risk team in an organisation. We've probably got a monthly meeting where we sit down and we've got some reports, and we look at the reports and we go, something's changed here, or this is not quite what we expected it to be. And somebody's probably gone off and built those reports, and they've spent a period of time in kind of creating that. For us, the first kind of real world application for AI is to look into the data sets that would form these types of reports. So obviously we've got dashboards and analytics and all that kind of good stuff, but the AI sitting on top of that basically looks for anomaly detection within that data set. So rather than it being the traditional thing of you having to wait for somebody to go look and figure out if there is an issue here, the first practical example for us in AI is just literally to look for anomaly detection. So it's going off and it's looking within the data set to go, well, actually, you've got a spike in a particular type of events here, or maybe you've had a spike in reports of bullying, for example, at a particular location. You might not necessarily see that in the data because it might be really low level, and it might be hidden in the fact that you've got lots of other things going on within the organization. So that's a really key one for us. And then again, AI without an output is almost meaningless. So the circle, if you like, for us is we're the mechanism for bringing the data in. The workflows then would be generating whatever the process is for the falls or the wounds or whatever the thing is that's happening. The AI, should I say, then picks up any anomalies in that. But then we plug the workflow back into the artificial intelligence to now drive some action from it. So the example I always use, because it's a relatively straightforward one, is you've got lots of infection events happening disparately across a geography, maybe a national territory. And traditionally, it probably take a long time to suddenly figure out that there's something going on here. Our system immediately picks up that there's something going on and you've had a spike in infections, generates an outbreak event via the AI detecting that, generates a workflow process. And for us, the workflow process could be notifications into people to say, well, there's an outbreak at these particular sites. So really practical, excuse me, and about reducing that time to act. So you've gone from me and you in our monthly meeting looking at some data, trying to figure out if there's anything going wrong there, to literally instantly something's happened. And not only are we telling you something's happened, we're also giving you the process that you've created to say, well, what do I want to do when this thing happens? So, really, I think transformational in terms of how people kind of manage risk within organizations, and then take that concept and move it into anything. You can just basically underpin these data sets, as I say, it could be, and data that's not necessarily from our products, well-being data. We've got a correlation between poor well-being reports of our staff and maybe a spike in certain types of incidents. Maybe there's a correlation between well-being and people are reporting bullying, again, for example, or violence and aggression, that type of thing. Again, system will automatically pick that up and flag it to you.
Yeah, and I suppose, and then you can immediately understand the power when you're plugging in something like a Cerner or an Epic or whatever the EHI PR system is. Mm-hmm. When you're plugging that in, not only are the things you just described where we're automating, detecting these things and affecting the response, then all that data is being pulled together to identify the deviation.
Yeah, absolutely. And it's able to correlate between it. Obviously relatively in the news at the minute in terms of kind of maternity, but imagine that labour, you've got some of the EP009 triggers there that would have been detected. You would have suddenly seen this, even nationally, well, we've got a spike here, and it would have generated an event on the back of it.
So what's
rather than being discretionary.
Yeah, that's the key thing here, isn't it? Though I think as well. I was having this conversation this week about the determinants of various factors that filter down to patient harm.
Yeah,
and interestingly, picking up from sentiment analysis, which you were just saying, where people are, if staff are pressured and feeling that they're not in a great place, staffing levels, other data sets, there are lots of contributing factors that might be very small in their own right.
Absolutely.
But as a collective, they can feed into, ultimately an organisation not delivering the best healthcare outcomes.
And without a system to see that, you're relying on people to try and get you that information. And we know, because we work with quite a lot of organisations still working on Excel spreadsheets. And so this is, I used the word transformational before, but it literally is. It's taking them from, people who are going off and trying to analyse and who aren't obviously SMEs other than the data element, try to figure out what's going on from a big picture point of view. And then it's reliant on the meeting and the discussion about the data. This is just, you're acting on it. And then I didn't touch on the RPA. So again, for us, some of the process elements and some of the workflow elements don't necessarily need to be handled within Radar. So if you think of our workflows, typically here's a task for you to do. You need to complete it. You need to put some information into a system. The way the API is being developed is it allows us to pass information back into other platforms. So some of the RPA might be just feeding a process back into another piece of software that then goes off and kicks off another particular process. Or going a step forwards, you could actually start to plug RPA into some elements of Radar. So things like replying to a complainant, for argument's sake. That thing's now no longer something that a human has to do. It's just, creates a document, sends it out to an email.
In the simplest of terms, then, the RPA, if you like, is any business process that I need to follow that has a reliance on human intervention and manual process.
Yeah, something that's
can
repeatable.
Effectively be digitized. Yeah. So that you can affect that efficiency and change.
Yeah,
you've talked a lot about the interoperability, this development of an API, and I know there's work that's gone around in conjunction with the Innovate UK, and specifically about how these integrations and this interoperability, this automation, can be applied into the kind of aging population, and those healthcare providers that service that kind of sector. And I think the overarching mission, if you like, was, how do we increase greater independence and quality of life and choice for the Asian population? You want to tell us a little bit about what is the Innovate UK and how that links into what we've just been talking about?
So I guess I just probably oversimplifying that, but Innovate UK is like a government pot of funds that they, almost like a tender process, if you were, you're almost kind of tendering for the money, for want of a better way of describing it. And the particular kind of national strategy, and I'll read it out because I won't get it right otherwise. Advanced data integration for improved care delivery to address an aging society grand challenge. So I think you explained it simpler than the title. But in principle, how do we use our technology to basically improve care for an aging society? For us, obviously, we're already working in care. So, we have a product that delivers a value there already. So the IUK fund for us was around how do we then influence that and where are we best placed to make a difference? And touching on some of the things we talked about, that reduction in time to act, but also freeing up carers to be able to deliver care specifically and allow care to be delivered without necessarily people being involved. So we talked about kind of care at home and devices and all that kind of good stuff. So we're using the API technology that we've built out to basically underpin, almost like underpin a care home, to one of a better way of describing it. So if you think of some of the transactional things people have got to do, like duplicating effort in terms of reporting things, like some of the report RPA you discussed, some really simple things like fridge monitoring and temperature checks and acoustic monitoring and all the kind of devices that they might have in a home where somebody's walking around sometimes and just checking the fridge and going, yes, it's 6 degrees, tick, and all of that kind of transactional activity. Because we're now able to pull in the data from these other systems. So for example, we might pull in the data from the fridges. So you're now no longer having to go off and manually check what that temperature is. But then when the thing goes wrong, workflow process, we're picking up that action to make sure that thing's mandated. So there's some kind of really simple ways we're able to help. And that frees the care up. So basically, instead of carers spending, an hour a day going off and doing these checks, you're now able to deliver care. So it has a material difference on the care that's being delivered because all of that time's been freed up.
You mentioned there about, and it's clear to see the efficiencies and benefits at a care home level within there. And, I spent many days in care homes, fortunately, that, customers welcome us in there.
Yeah.
And the thing that I always comes across is bedside time with the residents, and the patients, because that's ultimately what they want to do. And that, as you rightly pointed out, the administrative burden, if we can take that away. I suppose going a step further, though, is, and something that I know we've started to engage with ICBs and ICSs, integrated care boards and integrated care systems. And I suppose, does the Innovate UK this innovation help us also connect the home to the care home to the hospital?
Yeah,
is that the vision?
You think of hospital. I'm going to probably get the numbers wrong, but I think kind of cost of somebody in a hospital bed per day, about £2,000 per day, something around that. And then within a care home, not private, but £100 a day for argument's sake. So there's a big cost differential there. So if you think of you're in hospital and we're trying to obviously get you out of hospital. Ideally, you want to go home, but maybe you can't. Maybe your care means you got to go into a home. The first element of that is, well, where do you go and who can take you, and do they have the right can they support you in the right way? So the system, again with the interoperability, we can kind of get big picture view and understand, well, actually here are the people that are wanting to go out into a particular care home. Maybe that care home can or cannot take that particular individual. The workflow or the process can be almost the sign-off between us to say, well, actually, we want to discharge Paul into care home X. Care home X goes, well, yes, I want to take Paul. The process then becomes something that's much faster because it's done digitally, so you're not having to kind of do it in the traditional way. And then you're, in the nicest sense, moved quickly into a care environment where you're actually getting the care that you need rather than it being kind of delayed. You sat in a hospital bed, delaying the rest of the process within the hospital because you're taking up a bed.
And I suppose that going back to the API, which is, again, we should probably throwing out acronyms that assume people know what that means, but ultimately an intelligent way for our system to connect with other systems is, because I know one thing that was mapped out almost was that there are systems that exist to assist hospitals with observations to present discharge candidates.
Yeah.
We know that delayed transfers of care, again, without being held to a number, I know it was around about 6,000 patients per day pre-pandemic are in hospital that don't need to be in hospital, but to your point, not able to send them home.
Yeah.
So if we connect, I suppose the panacea system would be connect to the observations, expedite discharge. Could you hook in patient transport to?
Yeah, absolutely. I mean, patient
visibility
transport is likely to be a customer as well. We have that in joined up ecosystem.
Yeah, and I suppose then you're helping with the delayed transfer of cares to get people into safely discharged into where there is capacity and capability.
Yeah.
And then following on into the home because you're connecting into the home as well.
Yeah, and obviously we'll be feeding into the care planning software and vice versa.
And then so all of this technology, it's having a demonstrable impact, a positive impact on efficiency and things like that. From a cultural perspective, what's been the kind of feedback from people that are, whether I'm a carer, I'm a physician, a surgeon, whatever it might be, are they generally what is the cultural impact within an organisation?
I think if we pick the IHI trigger work that we've been doing with the EHS, I mean, it's enormous. For them, this is world first, and that fact of now you're not having to go down the traditional route of raising all these different types of events we've been mentioning, having to go off and do that within a particular system. Just that benefit of it, but I think the bigger benefit of it from a cultural point of view is you now know these things are happening, and more importantly, the learnings and the outcomes from them. So all the stuff we've been talking about is still inputs and still stuff going into a system. It becomes meaningless if we're just generating these things and we got lots of numbers if we're not then learning from this and actually thinking, well, what do we then need to do to reduce these? So great, we're getting lots of triggers coming in and generating events. Reality is we don't want those things to be coming into in the first place. So from a cultural point of view, it's really that of actually there's no barriers to reporting. There's no kind of negativity around reporting. If you think of traditionally, again, sometimes reporting things into a system, people feel like it's a negative thing. I'm reporting on this, and maybe I'm reporting on something that maybe involves you, and I don't want to report it. Now, actually, all of that has gone. But then the learnings from the processes and the things that come after help you implement something as an organisation to reduce these things happening in the first place. So that is what we're about.
Yeah. And I think if I'm working in an organisation, I see that we are moving in the right direction. I've got more time at the bedside, etc., etc. The things that I've said are important to me. Then I'm going to be in a better place. I just want to touch on a couple of things that you said about, the perception of reporting, where you take out almost the emotion out because we have to surface this thing because it's happened.
Yep.
Now let's try and learn from it to affect a change and stop it happening.
Yep.
And it's really important to be a learning management system as well as managing the incidents. But from a cultural perspective as well, I know that something that we do with some of the customers is excellence reporting.
Yep.
And then this term came up. I think it was with Cleveland Clinic and the way that they do it, which is a good catch.
Yes.
Which I think I love that terminology because it isn't I am reporting an incident. It is, it's celebrated that somebody has identified an area of, cliched a little bit, or an area for improvement, but it absolutely is.
Yeah, 100%.
We've found something, caught it. We're going to affect a change that's going to ripple through and stop this thing happening.
And then if the negative things are almost taken care of because they're done programmatically, for want of a better way of explaining it, then actually the system becomes just that. It's about, well, actually, here's something we can learn. Here's good practice. Here's a good catch. Here's some excellence reporting. And again, all of that feeds back into the system to help with the learnings. I think one of the things we didn't touch on in the AI is about things like the sentiment analysis and things like that. So actually, starting to analyse and look for things within some of the narratives people are saying as well. So again, coming away from traditionally drop-down boxes and people putting things in and becoming much more, a bit like after action reviews. What was your experience? What do you think happened as part of this? And us being able to kind of understand and determine, the factors from the text and the things people are saying, rather than just being, your traditional filling in a form, which I think again is going to be huge difference.
Yeah, that's going back to the point I made where I was speaking about people saying there's lots of different contributing factors.
Yeah.
That might be very small in their own right, but that feed into something. And again, the conversation, it will come to me, who I was actually with. But and they said they'd actually picked up from the huddles certain language.
Yeah.
Frustration, anger, what things that have a negative connotation, that a culmination of those at the same time they were having a spiking, patient harm event. So you can see how the things are kind of intrinsically linked.
Yeah. And again, you think if there's no system to do that, how difficult is that to do? I mean, it's impossible, isn't it? You never get, unless you're there, or unless you're out on the wards and you're listening, and it's really difficult to be able to understand.
Yeah.
That. So just that, like the heartbeat of what's going on within an organisation. From ultimately, for us, obviously we talk about it in a risk sense, but if you're feeding in the well-being data and the other elements of it, friends and family, if we're talking about NHS, that type of thing, you'd be able to amalgamate that and get an idea about what's going on.
I think just keeping on the culture thing, it is so important for us as as Radar Healthcare and a technology partner to healthcare organisations, is to understand that, because you would like to think that if when you bring a system in, because we're talking about monitoring what people are writing or saying, then is it Big Brother listening to me? But if it's done in a way that and people understand the end outcome of this, the net result is it's going to help us, improve, whether that's internally, culturally, looking our staff, or to how we deliver care to patients, then I think getting that balance right, that this isn't Big Brother and listening to everything you're doing and going back to it's a good catch. It's a good thing to find these things.
I think the way to do that is, and some people don't necessarily like this term, but kind of democratizing the information that comes out of the other side of it. So again, some of the things we're talking about, you're reporting things and they disappear off into the ether, and whatever happened to it? Where did I've been? What's going on with this? So again, one of the big things we are doing at the moment, to be fair, is how do you enable access for the type of insight that we were talking about for somebody in a head of quality or head of risk role. Actually, that sort of insight should be available to everybody in the organisation. And how do you surface it? So give them access to it in a way that again makes it easy for them to be able to consume. So if you think of the types of even the dashboards within our own product, you've got to have a certain level of data literacy, for want of a better way of describing it. So go on, look at a dashboard, understand what it's doing and understand what it's telling you. One of the things we're doing in conjunction with the IUK project is to actually take the analytics and to, again, I use the word surface, but to basically be able to present it to people in a way that makes more sense to them. And that things like augmented analytics, so integrating, I know it's kind of flavour of the month, but things like ChatGPT, where you go off and, a bit like natural language query, and you go off and you'd ask a question, and then it'd go off into our analytics, come back and present you with the information in different ways that you could then kind of consume. So maybe we're on a Teams meeting, for argument's sake, and we're just saying, well, okay, how many complaints did we have last week? And the chat pops up. So you're not even going into Radar. You don't even need to necessarily know Radar exists, but we're feeding with the source of this information for you, and that can be at any level.
Yeah, no, that I mean that's here and now, isn't it?
We're doing that now.
Yeah, it's not something that's visionary. It is getting the right information quickly there. I mean, you mentioned there about the democratization of data. I think that's really important as well. And I know, one of the benefits of the Radar kind of, because it's kind of personalized and role-based, it's that ability to push meaningful information to that person based on their role and requirement, and having it understandable. And then I don't know if you just want to briefly mention about, I know we call it Pulse. Yeah. But again, I think it's a key thing that, it is almost that democratization of data for me.
The things that I'm interested in.
The things that I'm interested in.
I mean, one is the analytics allows complete customization of the type of data you might want to consume. So you can go from anything from, I just want a table of some data, to, right, I want a specific dashboard that's maybe focused on pick maternity again, and it's tracking the numbers of claims we've got versus the number of incidents we've got, and it's maybe benchmarking me against the national average, and it's bringing in my audit data, bringing in my staff training. So from the analytics point of view, we can build very customized, very bespoke, for want of a better word, content that speaks to a specific need. And then, as you say, then personalizing that even further to say, well, actually, what am I interested in? So I've got my OKRs or my KPIs or the things that I might want to kind of have as an indicator. I can then create my own rule set around that to say, well, actually, if my audit's hit a certain level or fall under a certain level, please let me know. If incidents spike in a certain area, please let me know. So it will let the system will just go, Paul, this thing that you were interested in, here's some data associated with it, and it's met or hasn't met the particular criteria you were interested in. But then again, going forwards, we can plug that workflow in, plug that process in. So if you want rules and things to happen once these KPIs, these pulses are met, the system can do that as well.
I mean, that sounds incredible. As you know, I don't have the capability and the know-how to create all those things. Is it simple? Is it?
Yeah, I think that again, that's the benefit of it. All of this stuff is kind of drag and drop. So you don't necessarily need a degree in kind of data science to be putting these dashboards together. And one of the things that I think is really great is when we're working with the customers in terms of the dashboards designs. Sometimes you might have somebody who's kind of BI, so their job is data, their job is to put the charts together. But then other times you've got people who want to build something out that's very specific to them. So maybe it is maternity, it's a nurse within a particular specialty, and the bit that's great is once they understand what's possible, it's just opened up a whole world to them of, actually, I've always wanted to know this, and I've never been able to understand this because nobody's ever been able to give me the data for it. And now I can have a dashboard for this, they enable their own transformational change because they're now able to answer the questions that they've historically, they've never been able to do because they've never been able to go to even big organizations. I need this report. You're going into a BI team who's then going to go off and do it, or somebody else is doing it in the back room somewhere. We're now completely different to that. And that when you see them getting excited about how they can change what they do and learn from it, it's amazing.
Yeah, I like the idea of just being able to drag and drop and start to set some thresholds and say, just tell me when this thing occurs, or if I start to fall, or if there's a change. Yeah. In a very simple way.
Yeah, and they're building things that we learn from as well. So in the nicest sense, we see customers that build a dashboard and we're like, that's great. We learn from the things that you're constructing. And same way we develop the product, you end up with this community of customers who are creating content that is then shared with us, obviously, but then also shared with each other. So again, NHS starting to share dashboards with each other, starting to understand, well, we do this and we do that, and that's a great dashboard. We'd like to take learnings from that.
Yeah, I do. I just touch on the community actually, because I think that's an amazing place that, because you have, US, UAE, NHS, health and social care, GP, then you've got a big mix of different organisations all feeding into one community and seeing how people are working, best practice. I think seeing that actually people are sharing things is pretty cool. And then I don't know if you can remember the stats as to how we listen and push things back out.
I can't remember the actual numbers of requests through the forum, but ultimately 50% of the things that come through from a product suggestion from the customer base end up in the products in some way, shape or form to date. So we're always, we've got lots of ways of listening. One of them's the community, one of them's people putting stuff onto the forums. Obviously, we've got the CSMs, the PMs, sales, yourself, me, we're all kind of out there always listening to customers and what the market's interested in. But yeah, directly through the forum, it's 50% of things that I've asked for, we've developed, which I would be surprised if many are in around that number.
Yeah, no, it's pretty impressive. Just you just mentioned about the ease of use. Where is that in terms of your priority? Is it front and center from a user-centric? Yeah. Because to throw in another acronym, which I'll let you describe, is NLP, the kind of natural language. Again, it's all oriented to be a really slick interaction with Radar Healthcare. You almost want it nominal in terms of what I need to do, but I communicate with Radar, it's communicating with me, and we're affecting a change.
The ethos of the design is always kind of more acronyms. UCD, user-centered design. So when we're developing anything, we're also always developing it with the end user in mind, even down to the beta sessions and things we do. So that's where we kind of, we're developing some part of the product, and we're asking customers who've been involved in the design journey to help us test it. We kind of set them tasks and say, okay, I need you to do X within Radar. And then we kind of sit back and see how they get on and see if they're struggling in anywhere, and that helps us with the design. But to the the point you were making there, I think for us, sometimes you don't necessarily even need to be in radar to be consuming the things that are coming out of radar. So from an accessibility point of view, back to things like the analytics and the RPA and the natural language, you might be querying the data within radar from something else like Teams or Slack or wherever you spend your time. That again is about usability. Some of it you don't even need to know where they're. You might be just consuming an outcome from us, which is you need to go off and you need to take some. Pharmacist, the meds fridge is running too warm. You need to go off and you need to empty the fridge and make sure the medicines are either transferred or they're disposed of safely. Don't need to know that's even radar.
Yeah, I suppose that is the RPA element always is. Yeah. There's things working in the background doing those things that historically we would have spent time and energy on, whereas now I'm focusing on actual care delivery.
Yeah. And
making more informed decisions.
Yeah, basically all about reducing the time to act. We're making sure that you're not anything that you need to do is immediate. We're just keeping you on the hook for whatever it is that needs to happen within the organisation. And when you do need to consume some of the information, it's just as simple and straightforward as possible and is relevant for you in your particular role, which is where kind of all that analytics and dashboard design comes in.
Thank you so much, Mark. That's been. I just always find it insightful. I think just. This is what excites me is the innovation side of things. But many thanks for joining. Thanks for everybody for listening. We'll be back in a couple of weeks with another podcast. If you have any feedback, please rate and subscribe on What the HealthTech. And if you want any questions, then please email whatthehealthtech@radarhealthcare.com. Thank you very much, and thank you, Mark.
Thank you.